Door. Start हो गया. Good morning, friends. Today is our last lecture related to the revision classes, which we have started taking in forms of question answers. We have started from 2020, and now we are ending at 2008. So 12 years questions, all long questions we have solved. I hope this has been of some help to you. So what you are supposed to do is now to understand, try to read those questions, because if you properly see, most of the questions are repeated. You should have some understanding about the theory, which is very important. And now we'll go to 2008. Okay, the question, see here, the goiter question was repeated almost on the same year. The only difference was it was a defined goiter. Next question was discuss the classification. That means there are few things here and there, but the whole concept remains same. So for us, there are 5 questions today, and one of them is most common is blood products. We'll consider what is actually we mean by blood products. We have to discuss their indications, complications, and the treatment following blood transfusion reaction. Okay, what actually happens after the blood transfusion and what you are supposed to do. In short, what is transfusion? First, amount of blood withdrawn is 450 ml. One can donate blood 3 times a year. Every unit of blood is screened for A, vitamin, hepatitis B, hepatitis C, HIV 1 and 2, and syphilis. And there is a concept in particularly surgery that is called as autologous blood. It takes away major problems, but what we are doing here, the patient himself will pre-donate the blood 3 weeks before surgery. So as a principle, the blood will regenerate within 3 weeks and patient will be normal, and same blood can be donated back to the patient at the time of planned surgery. Okay, this is the concept of autologous blood. Remember this is also for a short note of 2 marks. So what are the actual blood components we are giving and how they are stored? This you must know. Whole blood stored at 1 to 6 degrees centigrade. The shelf life is 35 days. Okay. Packed cells. Packed cells can be stored at room temperature. Shelf life is 42 days. Platelets. See, platelets have got a very short shelf life, that is only 5 days. But they have to be stored as 20 to 25 degrees centigrade, that means almost at the room temperature. FFP, fresh frozen plasma, stored at 40 degrees, and this can remain for 2 years. Cryoprecipitate, minus 30 degrees, stored for 2 years. That means these two things can be stored and if required can be given to the patient, because these do not need anti-D compatibility. Okay, this is important. So what are the various blood products? The question is, what are the various blood products? So this is graph itself shows you how what actually they are. Fresh blood, that is fresh whole blood. Packed red cells, FFP, cryoprecipitate, platelet, and PCC, that is prothrombin complex concentrate. Just go through this chart seriously. It will give the answer of every question. Fresh whole blood, rich in coagulation factor than prothrombin complex and more metabolically active than a stored blood. See the difference. Fresh blood should always be preferred because it is more active than a stored blood. Also available as a 450 ml pack. What it contains? RBC, WBC, plasma and platelets. The essential indication is massive bleeding and major surgeries where you need a fresh whole blood. Packed red cells, actually they are spun down and concentrated through the centrifuge. It is 330 ml. Hematocrit means concentration of RBC is 50 to 70%. Here we are storing in what is called as SAG-M. SAG stands for saline adenine glucose mannitol. This is a different medium. The advantage of this medium over the routine CPD medium is it can be stored for 5 weeks. And in CPD, you can store them for 2 to 3 weeks. PRC, packed red cells, will increase hemoglobin by 1 gram per cent. And the hematocrit value, that means concentration of RBC, by 1%. Okay. What is FFP? Fresh frozen plasma. It is very important because this is very rich in coagulation factors. It is stored at 40 to 60 degrees and shelf life 2 years. Rh positive FFP can be given to negative RHD. This is very important and mainly used for all the conditions of thrombocythemia and mainly dengue fever like conditions in pediatric age. It is available in 200 to 250 ml pack. Cryoprecipitate, it is more supernatant. It is what remains at the top. It is rich in factor 8 fibrinogen. So this is the top, and what you get fresh frozen is below. After centrifugation, the superficial is cryoprecipitate. It is stored at 30 degrees for 2 years. Availability 15 ml. Okay, and platelets. Platelets are available as pooled platelet concentrate. It contains high volume, that is 250 million per liter. The volume of platelet available is 50 to 70 ml, and it has to be stored in agitator so that they do not remain in the base. It has to be continuously rotated like this agitator, and unfortunately half-life is only 5 days. The indication is thrombocytopenia, dengue fever. Same like FFP, but platelets are preferred whenever the platelet count goes below 50,000. Initially it was 1 million, 50,000, and now people say if it goes below 20,000, then only give platelet. Prothrombin complex, it is a pooled concentrated plasma. It contains factor 10, 9 and 2. These three factors, and factor 7 is added separately. Okay, so this is what is the various blood products, their uses, their storage and indications. Okay, so going into the details. Packed cells obtained by centrifugation. Storage 1 to 6 degrees. Plasma, it is different fragments. It can be again gone into human albumin is also one of the factor. 4.5 is obtained by repeated fractionization, and it can be stored at in freeze 4 degrees centigrade for several months. FFP also, it can be stored for 2 years. Uses severe liver diseases with abnormal coagulation function. Cryoprecipitate, it is rich in factor 8. Plus fibrinogen, factor 8 and factor 9 concentrate. They are also separately available. PRP, platelet rich plasma, now used very commonly. It is freshly donated blood at 150 to 2000 gyration, 200 gyrations for 15 to 20 minutes in centrifuge machine. Platelet concentrate volume is 1500. Here also same rotation. 50 ml stored at room temperature on agitator for 5 days. Each unit has got 5000 to 10,000 platelets. ABO to ABO compatibility is not required for all the fractions. PCC we have discussed. Okay. So what are the indications of blood transfusion? This was the question. Ideal indications are acute blood loss following trauma. Mainly whenever the blood loss is more than 50% of a total body volume. and in otherwise healthy individuals. Most common indications are like in surgery, liver, spleen, kidney trauma, and perineal injuries, major fractures, where blood loss can be more than 1500 to 2000, that means 2 liters, mainly occurs in fracture pelvis and fracture of the femur. Major surgeries following burns, in septicemia as a prophylaxis, and whole blood is given in acute blood loss, and packed cells are given in chronic anemia. This you must know. In chronic anemia, we do not give total blood transfusion because it will lead to increased volume. And blood fractions are given in hemophilias. Donor criteria. Remember them. You must be knowing it. Donors should be fit without any serious illness and HIV 1 and 2 infection. Weight of the donor should be more than 45 kg. How it is collected? It is collected in a bag containing 75 ml of CPD or SAG-M blood. CPD blood stored for 3 weeks. SAG-M blood stored for 5 weeks. And the principles of transfusion, after grouping and cross matching every time 550 ml of blood is transfused in 4 hours. How do you do that? Ideally it is 40 drops per minute whenever the blood transfusion is planned. In emergency things are different. The drip set is filtered drip set, and 1 liter of a blood bottle contains 350 milligram of iron. Okay, and this chart shows in stored blood RBCs last for 3 weeks. WBCs are destroyed rapidly. Platelet also get reduced in 24 hours. Okay, clotting factors are liable, so their level fall very quickly. Stored blood has got its own limitations. Okay, now going to the complications. Last time we have considered complications, this time also we will consider complications in short. The most common complication of a blood transfusion is febrile non-hemolytic transfusion reaction. If you write down this much, you are passed. Okay. Other type of reactions. Reactions mainly occur because of a febrile non-hemolytic transfusion reaction. It is FNHTR. There can be an allergic reaction to the blood we are talking. There can be delayed hemolytic, and most important is transfusion related acute lung injury. I have written in red, it is TRALI, TRALI. It is major cause for mortality after blood transfusion reaction. This can also be asked in short note. We will discuss about it. The reactions can be acute hemolytic, fatal hemolytic, and anaphylactic. Okay. What are the infections? These are the complications. Infections of all hepatitis, HIV, malaria. In Western countries, West Nile fever, parvovirus, HIV-8 and congenital megavirus, that is CMV. Other complications is allosensitization to RBCs. HLA compatibility allosensitization. This is important. And most important is graft versus host reaction, where the body considers that blood as a foreign body. So it is a graft versus host reaction. This is severe. Metabolic complications of massive blood transfusion are in general fluid overload, because we are giving massive means total body blood is transfused within 24 hours, okay, or more than 2500 ml within 6 hours. This is the definition. Fluid overload, hypothermia, and impaired oxygen delivering capacity. Okay, if you give major blood, there is no time for the body to adjust. Electrolyte imbalance like hyperkalemia, hypocalcemia, hypomagnesemia, metabolic alkalosis. Metabolic alkalosis is common after massive BT, not metabolic acidosis. This is for MCQ. Metabolic alkalosis most common after massive blood transfusion. Okay. So these are again complications we have repeated. You can go through this whenever you get time. And note regarding blood substitute. Blood substitutes are many. Substitute means not actual blood. Okay, you are getting the blood components are different and blood substitutes are different. Components are like FFP, cryoprecipitate. Then what we have discussed is a whole blood. They are a blood different organs, different parts of blood. But blood substitute means these are artificial. Artificial blood substitutes are like this. First commonly used is human albumin, most commonly used, and they are all colloids. You know the difference between crystalline and colloid. Colloid maintain the volume for a very long time due to the high molecular weight of the substitute of the colloid. Major advantage, no risk of transmitting hepatitis. Okay, plasma fractionation will extract albumin from blood. Main indications, cirrhosis, burns, nephropathy syndrome, and all types of major 1 gram albumin binds with 14 ml of water. Crystalloid do not increase the volume because they are immediately washed off. Here albumin binds to 14 ml of water. So what will happen? Blood volume will be increased. The volume will not be limited, and albumin is infused daily as needed according to response. But albumin is expensive. Next is dextrans in the category of colloid, blood substitute. They are polysaccharides of varying molecular weights derived from Lacunostoc mesenteric bacteria. Here 1 ml binds with 20 ml of water. Dextrans are of two types. In OT you will come to know Dextran 40, Dextran 70. Dextran 40 is effective for restoring blood volume immediately. So if there is a major volume hypovolemia due to blood loss, we must give Dextran. But here the small molecules are rapidly excreted in kidney, so effect is transitory. And high molecular weight dextran like Dextran 110 and Dextran 70, they are long acting. So they are used whenever you expect a prolonged effect of a concentration. Precautions you must take. Blood samples for blood group and cross matching should be taken before giving colloid, because colloids interfere with the blood grouping of the patient. They also affect platelet function. Unfortunately, these may precipitate abnormal bleeding, and total volume of dextrans should not exceed 1000 ml. Okay. Another type is gelatin. It is in laboratory, that means synthetic. It is used as a plasma expander, and trade name given is Hemacil, very commonly used. It is less effective than dextran, but it remains intravascular. What it is? Hydroxyethyl starch. That also contains starch and sodium hydroxide. Here the whole purpose is maintaining the blood volume. Blood substitutes are there to maintain the blood volume. Commonest human albumin, dextran and Hemacil. Write down 3, that is enough. Okay. Same. Human albumin, dextran. Then what is the protocol of transfusion? Everybody must know about it. That protocol is blood transfusion should commence within 30 minutes of removing from the freezer. No time should be wasted. RBC or whole blood must complete within 4 hours. Platelet and FFP transfusion within 20 minutes. The transfusion set should have a 170 micrometer size filter. Preferably give the blood only through blood transfusion BT set, not by the routine IV set. The needle size should be 18 to 19 number gauge. It should be large so that very fast blood transfusion can be given as a life-saving measure. Okay, then what about mismatched blood transfusion? How do you know that the patient is having a mismatch? Many times the patients are under sedation in OT. Okay, so patient cannot tell you I am getting this complaint. So what are the signs? In OT, during blood transfusion, diffused bleeding from wound and all sides. Okay, diffuse unexplained bleeding with hypotension is important sign of a mismatched blood transfusion. In conscious patient, patient feels heat and pain along the vein through which the blood is transfused. In conscious patient, signs of hemolytic reaction are oliguria and hemoglobinuria, that means bleeding through urine. These are the how you understand transfusion reaction. Also, tachycardia, tachypnea, sweating, anaphylactic reactions or anaphylactic signs will also be manifested. So, what is short note for? We have considered probably last time. Just to revise, what is a massive blood transfusion? It is defined as replacement or transfusion of blood equivalent to patient's blood volume in 24 hours, and it depends on age. Adult 5 to 6 liters, infant 85 ml per kg of body weight. Second definition, single transfusion of blood more than 2500 ml in continuity. Okay, this is a massive blood transfusion used for all severe traumas and during usually surgical bleeding. This is a primary hemorrhage table. Adverse reactions are many. Electrolyte imbalance like hypocalcemia, hyperkalemia and acidosis. All coagulopathies like DIC. This is the most dangerous. Dilutional thrombocytopenia. DIC is disseminated intravascular coagulopathy. There can be citrate toxicity because it is given to citrate. Temperature will come down, hypothermia. Oxygen delivery will be affected, and we can expect lot many infections. But more transfusion reaction major is ARDS, DIC, and congestive cardiac failure. You remember only ARDS, DIC, and CCF as a reaction to massive blood transfusion. So, in short, what are the adverse blood transfusion reactions commonly seen? Most common signs are fever, chills, hives means patches, itching. Usually these reactions are very mild. These resolve with or without treatment, but the blood has to be stopped. Okay. More severe like respiratory distress, low BP, high fever. Again, blood transfusion must be stopped. Observation in ICU management. All the associated signs should be managed in ICU. More important is acute transfusion reactions. What it is? These reactions occur even when the correct cross-matched blood is given. Many of the symptoms because of a mismatched blood, but this occurs even the rightly cross-matched blood is given. They can be simple allergy, rash, itching. The treatment is stop the blood transfusion and antihistaminic. Anaphylactic reaction, this is for the IgA antibodies. Symptoms flushing, swelling, itching, difficulty in breathing, wheezing, vomiting and low BP. This is probably more bad. Treatment must be very active. The mainstay, stop beating. Epinephrine, steroid, antihistaminic, bronchodilators. Febrile non-hemolytic. What it is? Unexplained rise in temperature during or up to 4 hours after blood transfusion. This is probably reaction to the WBC of a new blood. Treatment, stop beating, investigate and antipyretic. But fortunately these are not detrimental to life. This is acute hemolytic transfusion reaction. Previously it is acute non-hemolytic. What it is here? the body destroys the donated RBCs. Okay, the donated RBCs are destroyed by body himself. There is a chance of renal failure, hypotension, hematuria, and flank pain. Remember, whenever patient complains of a pain in flank related to kidney, always think of a hemolytic transfusion reaction. Treatment, stop transfusion, and severity, IV, dialysis. Sometimes the bleeding supportive care has to be done. Similarly, there can be a septic reaction, that is infective reaction. The infection causes Staph aureus or platelet products. Treatment is signs, fever, chills. Treatment, the fluid, respiratory management, and antibiotic management. This TRALI, it is a transfusion-related acute lung injury. It develops very quickly. Antibodies in the donor blood react with recipient WBCs, and what it will result in? Pulmonary edema. Signs are severe shortness of breath. If the patient is running short of breath, be cautious. Low BP, the treatment is immediate. Oxygen, ventilator support, dialysis, because TRALI can be fatal where the mortality is between 5 to 25%. Last is transfusion associated circulatory overload, that is a TACO, where we are giving excessive blood. So treatment is oxygen, diuretic, and upright position. We don't want the excess blood go to the brain. So the treatment is upright position. Okay. So we have finished regarding all the blood substitute, blood complications and management. Next again question from general surgery. The question is, describe parenteral fluid therapy. Okay. So what is a need? What is the need of a parenteral fluid therapy? It is indirectly artificial nutrition. So what are the indications? Any patient who has sustained more than 7 days of inadequate intake, or any patient anticipated to have no intake for 7 days. Okay, this is how you define the indication for artificial nutrition. Not eating for 7 days, expected not to eat for 7 days. Okay, so what are the modes? What are the different modes? Common modes. The commonest mode is enteral nutrition. After that, it is a parenteral nutrition. What do you mean by enteral? It is given via gastrointestinal tract. The methods are slow sip feeding, tube feeding. Tube can be a rice tube. The tube can be nasojejunal tube. There can be feeding gastrostomy surgically done or feeding jejunostomy done usually in the carcinoma of stomach. It is called as FJ. This can be temporary, this can be permanent. Okay, enteral nutrition. And what is parenteral nutrition? Whenever the nutrition is given via veins, this can be either peripheral or it can be central parenteral. Okay, this is between enteral and parenteral nutrition. Parenteral, whenever you bypass the enteral system. So why do we go for parenteral nutrition? So what are the indications? Indications are all the patients having contraindications to enteral nutrition. That means those who are unable to take enteral nutrition will need parenteral nutrition. In case of complications of enteral nutrition, if patient has intractable vomiting, refractory diarrhea, high output physiology is the major indication, diffuse peritonitis and GI malabsorption. Similarly, severe burns and terminal malignancies. And whenever you need an access for more than 7 days, we have to think of a parenteral nutrition. So what are the types of parenteral nutrition? Two types, simple. Peripheral parenteral nutrition, that means nutrition is given by peripheral veins. It is good for even if you expect less than 2 weeks. If it is less than 2 weeks or 1 week requirement, parenteral is better, peripheral. But disadvantage is thrombophlebitis and repeated blockage of veins. In case of burns, you see so many times you have to keep on repeating that this venous section. It is one of the major headache for management. Then comes the central parenteral nutrition. It is a parenteral feeding whenever required for more than 2 weeks. Commonest route, subclavian is the best way. Next, external or internal jugular, rarely femoral. The infraclavicular subclavian is best because the tube will lie over chest. Observation is very good. Precaution, always post-insertion chest X-ray should be done to confirm tip of catheter and rule out pneumothorax. This is a major part. So what are the indications of a TPN, total parenteral nutrition? First, as a primary therapy, second, as a supportive therapy. Primary is GI fistula, renal failure, severe burns, hepatic failure, Crohn's disease and anorexia nervosa. This is slightly psychological disease. Supportive therapy in radiation, chemotoxicity, weight loss due to surgery and patient with malignancy and severe sepsis. To support the body, we are giving TPN. So what are the clinical conditions require cautious use of parenteral nutrition? May remember the word cautious use. Condition, hyperglycemia. What do you mean by that? Glucose more than 300 milligram. Azotemia, blood urea nitrogen more than 100 milligram. This is also indication. Hyperosmolarity, serum osmolarity more than 350 milliosmoles. Hypernatremia, here these conditions you have to be cautious. Hypernatremia means sodium more than 150 milliequivalent. Hypokalemia, potassium less than 3 milliequivalent. Hyperchloremic metabolic acidosis, what it is? Chloride more than 115 milliequivalents. Hypophosphatemia, phosphorus less than 2 mg. And hypochloremic metabolic alkalosis. In acidosis, chloride more than 115 and metabolic alkalosis, chloride less than 85. Okay, this is a graph. If possible, remember you are all taught in physiology. You can forget this. Composition of different solutions is very important. You can just go through it. I will discuss about that. So what are the TPN formulations? With lipid, usually they are called as 3-in-1 solution. Most easily available, and in one bottle you have got 3 compartments. Total kilocalories are maximum 2100 kilocalories, and out of that 20% as a lipid. Amino acid gives 420 calories. Major come from dextrose, that is 1260 kilocalories. Amino acids 105, dextrose 370, lipid 47. Total volume given is 1830 ml. Out of that, remember, dextrose is a major source of energy. Fat has got a highest source of energy of approximately 11 grams. Amino acids comparatively same like dextrose. Dextrose give 4 kilocalories per liter. Okay. So this is how it is. The formulation is 20, 25, 25 or 60, 20, 20. Without lipid, it is called as a lipid free. Amino acids 25%, dextrose 75%. With lipids, amino acid 20%, lipid 20%, dextrose 60%. Lipid free TPN is mainly used for cholestatic or liver failures. That is why 2. Non-lipid with lipid. Only remember this much. This is more than enough. Where do you get energy from? Mainly carbohydrate, lipid and amino acids. You are getting actual energy, that means you are getting calories. Non-energy electrolyte, trace elements, vitamin and water. Everything you are getting through by the 3-in-1 formula. So what are the complications? This is all good so far. Complications are mainly catheter related. metabolic, electrolyte disturbances, and there can be overfeeding due to excessive fat. Most common catheter related sepsis. Most dangerous complication pneumothorax. And if it is more fat, you have to stop immediately and start free TPN, that is fat free TPN. What TPN contains? Carbohydrates, proteins, fats, and essential amino acids. One thing of caution, whenever blood sugar is increased in total parent nutrition, we must suspect sepsis. So this chart shows complications of a parenteral nutrition. If you have time, you can go through this. Okay, this is very simple. Hypoglycemia causes excessive insulin. Treatment, stop insulin. Hyperglycemia, excess dextrose, start insulin. Hypotriglyceridemia, dextrose overfeeding, you have to go for fat emulsion restriction. Essential fatty acid deficiency, go for fat derivatives. Electrolyte and mineral abnormalities, inadequate monitoring, electrolyte should be checked. Azotemia is inadequate supplementation in TPN formula. The science is parental iron uncommonly increases. Metabolic bone diseases, elevated liver function, these are all for postgraduate level. But remember only hypoglycemia, hyperglycemia. Okay, these are two essential. So now we are going to goiter. This question was repeated many times, and you should be well aware of what is writing about goiter. First, goiter. Goiter is any palpable swelling of a thyroid gland, because thyroid is not palpable normally. The word goiter is derived from gutter, that is in front of throat. This you must write in any goiter. How do you classify them? First, goiter is an enlargement of thyroid gland. The classification is simple non-toxic, colloid, and solitary non-toxic. So simple non-toxic are diffuse hyperplastic, commonest is physiological, that is puberty or pregnancy. Primary iodine deficiency occurs in endemic areas. Secondary iodine deficiency due to the food habits. And fluoride excess areas. There are some endemic areas where there is a fluoride in water, mainly in coastal Andhra. There, this diffuse hyperplastic non-toxic simple goiter is common. Drugs. Main drugs these days actually not commonly used. It is excessive use of anti-thyroid drugs can cause goiter. PAS is it is used previously for tuberculosis treatment, now not used. And radioactive iodine. This is also not common in our country. A is diffuse hyperplastic, second is colloid goiter, nodular goiter, that means multinodular, solitary non-toxic nodule, and recurrent non-toxic nodule. These are the different types of a simple non-toxic goiter. This graph from Love Belly is beautiful. You should be in your front of your mind or eyes. Sorry. Simple goiter, euthyroid. Diffuse hyperplastic, multinodular. Causes physiological, pubertal pregnancy. Toxic, diffuse, that is Graves' disease. Multinodular and toxic adenomas. Euthyroid, toxic, neoplastic. Neoplastic means either a benign malignancy or a malignant. Inflammatory. Inflammatory can be autoimmune, granulomatous, fibrosing, and infective. These are all different types. Main concern for us is what is Hashimoto's disease, de Quervain's disease, and Riedel thyroiditis. These are the examples. Remember, Riedel thyroiditis is a painful thyroiditis. There can be infective thyroiditis. Rarely syphilitic or tuberculous infection can occur in thyroid. So how do you classify simple goiter, toxic goiter, neoplastic goiter, and inflammatory goiter? This four is very simple. Okay, diffuse, simple, toxic, neoplastic, inflammatory. In fact, this applies for any type of a swelling. Then comes the toxic. Toxic is Graves' multinodular, that is Plummer's, recurrent toxicity, neoplastic, adenoma, follicular, malignant, carcinoma, papillary, follicular, medullary, anaplastic. Thyroiditis, Hashimoto's, riddles. Same thing is repeated here. What are the factors involved are growth stimulating immunoglobulins and growth prone cell clones. So why this multinodular goiter occurring? Because of a churning. There are different ways. Internodular tissues are very active. First stage of hyperplasia and hypertrophy. Most important is fluctuations in TSH level is a major cause for multinodular goiter. Stage of formation of nodule, they are inactive. And colloid goiter is goiter due to long-standing iodine deficiency with localized accumulation of a significant colloid in the gland. Okay, so this is regarding multinodular goiter. So what are the clinical features of a MNG? Common in middle-aged females, 10:1. Slow progress over years. The nodules are of different sizes, occur in both lobes and isthmus. A recent increase signifies either hemorrhage or malignant. The positive coccus test, why it occurs? Because of compression over trachea, and it leads to scabbard trachea or tracheomalacia in a long-standing MNG. Nodules can be calcified to become hard, or they can undergo nephrotic necrosis to form a soft nodule. So what is this MNG? By definition, MNG is a discordant growth with functionally and structurally altered thyroid follicles. Okay, this is alteration into the thyroid follicle presenting as a multiple nodular thyroid. The cause is fluctuation in TSH levels. This is the most important cause. Other causes iron deficiency, goitrogens and hereditary. So what are the stages? Same. Hyperplasia, fluctuation and nodule formation. This is long-standing iodine deficiency. Many of them they are of different size, and different size signifies malignant transformation or hemorrhage. There are different tests. So how do you investigate? Very common. T3, T4, TSH and free T4. USG of neck, FNAC. Where FNAC should be done? FNAC should be done in the most dominant and suspicious nodule. So large nodule which is dominant and suspected of malignancy. X-ray neck, what it will show? It will show the trachea. Indirect laryngoscopy, it is very important pre-operatively for legal purpose, and if there is any occult recurrent laryngeal nerve palsy. Radioisotope scan for retrosternal goiter. This is a major condition. CT MRI. The treatment, usually surgery is preferred. The indication for surgery usually are, most common indication is cosmetic in females. It is an irreversible stage and chances of complications are very high, like toxicity, hemorrhage and follicular carcinoma. Seeing the future, it is better to operate and remove thyroid. But the major indication is cosmetic. So the treatment of choice and the only treatment is surgery or do nothing. Okay, these are the different types. Just remember, total thyroidectomy, subtotal thyroidectomy, partial thyroidectomy not done nowadays. Either we go for a total or subtotal. Adequate thyroidectomy is essential. Complete removal of disease without retaining is more preferable, and this patient need lifelong supplementation of thyroxine. The reason is high chances of recurrence in remaining thyroid, and resurgery in multinodular goiter is very difficult, and remaining gland also can undergo malignant changes. Then the another question. Another question is, discuss peptic ulcer, its complication and management. This is everyday's question. Everybody must know the answer for it. Everybody must know the difference between the gastric duodenal ulcer, their clinical feature, their causes and management. For this, there is no excuse because this is important for theory, day-to-day life and practicals. Nowadays, the peptic ulcer, the word defines both gastric and duodenal ulcer. There are so many signs symptoms are given, but practically without endoscopy, it is difficult to differentiate between a gastric and duodenal ulcer. You remember this. Why does the peptic ulcer occurs? Peptic ulcer occurs when an acid in digestive tract eats away the inner surface of your own stomach or duodenum. That means your own acid is eating your body. It is same like organisms, where the organisms, they are called as a fat easy eating bacteria. They eat your own cell. Similarly, your own ulcer, your own acid, if not controlled, it will eat your stomach. So the only answer is control the acid. And how are you going to do it? Either PPI or anti-H. pylori treatment. This is in short regarding all peptic ulcer, the etiology and management. But for detail, you must know the differences between gastric and duodenal ulcer. There are some differences. Find out. Gastric ulcer, the etiology commonest is atrophic gastritis. H. pylori 75%. Nowadays H. pylori is everywhere. Smoking alcohol, altered mucosal barrier, and gastric ulcer is more common in low socioeconomic strata. In this case, the reason is not excessive acid because these patients do have a chlorhydria or normochlorhydria. It is more common in cirrhotic patients. Okay, you are getting it. The cause is smoking alcohol and low economic status. Against duodenal ulcer etiology, it is a stress, anxiety. In short, what is it called as? Hurry, worry and curry. H. pylori, commonest cause 90%. The major cause is use of NSAID and steroids for a longer period. Duodenal ulcer is comparatively more common in O positive blood group. Endocrine, MEN1, Zollinger-Ellison syndrome, Cushing syndrome and hyperparathyroidism. Alcohol is everywhere. Alcohol, smoking, vitamin deficiency. Associated diseases, chronic pancreatitis and cirrhosis. Most common site for gastric ulcer is lesser curvature along incisura angularis. It is a type 1 type of a gastric ulcer. Duodenum, first part of duodenum is most common. Clinical feature, gastric ulcer, equal in both segments. Pain, it is said, more after taking food and relieved by vomiting, not always presentation. Pain uncommon during night. Hematemesis is better presentation. Patient has got a good appetite but afraid of eating due to pain. And there is a loss of weight. As against in duodenal, it is more common in males. Early morning pain and decreases after food. It is called as a hunger pain. Pain commonly occurs during night, that means early morning hours because the stomach is empty that time. Common presentation is melena. In gastric it is hematemesis, in duodenal it is melena. Here appetite is good, patient eats more frequently, then weight gain is probably the result. Okay, then investigations. Old Berry meal nowadays we are not doing. On berry meal finding is lesser curve with notch. Regular margin of ulcer called as a spoke wheel pattern. Mucosa overhanging and convergence of a mucosal fold towards the base of ulcer. Duodenal, commonest is deformed or absent duodenal cap. The reason is spasm. And trifolioduodenum, that is called as a secondary duodenal diverticulum. But more important is endoscopy. Now very commonly done to differentiate. Complications for a gastric. Most common complication of a gastric ulcer is perforation into lesser sac. That means posterior perforation. Patient can undergo what is called as a hourglass contracture in females. The contractures because of cicatrization occurs on the lesser core. There can be handbag stomach in females, and this ulcer is known to undergo malignant transformation. As against in DU, commonest complication is bleeding. Second comes perforation. Third is GOO, gastric outlet obstruction due to pyloric stenosis. In our last lecture, last question paper, we have considered in detail. Duodenal ulcers do not undergo malignant shape. Okay. So, what is the duodenal ulcer? More commonly asked. The complications and treatment. This chart is more than enough. I think you have already studied this in duodenal perforation. Intractable pain, highly selective vagotomy. But remember, these days, the treatment of a duodenal gastric ulcer is PPI plus anti-H. pylori treatment. If there is no response for a long time, then only you think of surgery, but don't do surgery. Surgery is mainly indicated for complications. But for a understanding purpose, intractable pain, HSV, that is highly selective vagotomy. Whenever patient has got bleeding, you operated him, patient is comfortable, then truncal vagotomy with pyloroplasty with suturing of a bleeding vessel. Perforated duodenum, surgery is must. Omental patch repair, that is a Graham's patch repair, and truncal vagotomy in stable patients. In obstruction, truncal vagotomy with enterectomy. Here you are going for Billroth 1. Truncal vagotomy GGO, it is Billroth 2. Intractable or bleeding, distal gastrectomy, truncal vagotomy with enterectomy. For a perforation, it is type 1 distal gastrectomy, type 2 and 3 the patch closure in unstable patient. And that is actually the treatment of choice. Truncal vagotomy not done these days. If there is obstruction, you have to think in terms of a bypass, either an enterectomy or gastrogenostomy. Okay. So what are the complications? If you want to write down, very simple. Intractability because of non-healing, bleeding most common complication, perforation most common complication, and 4 is GOO. Complications 4: intractable pain, bleeding, perforation, outlet obstruction. Bleeding perforation, most common indication for surgery. What bleeds? Gastroduodenal artery. All the posterior ulcers bleed and anterior ulcers perforate. Death occurs due to multiple organ failure. So treatment is saline, red blood cells, and figure of 8 suturing of a gastroduodenal artery. Vagotomy pyloroplasty if patient is stable. So this is in short bleeding peptic ulcer. Perforated peptic ulcer, we have considered in detail in our last lecture. It is present as acute abdomen. There are 3 stages. Chemical peritonitis is immediate, and dilutional stage, that is a stage of illusion, and last is a septic peritonitis which occurs after 6 hours. So it is called as a bacterial peritonitis whenever the infection supervenes the chemical peritonitis. There is a fluid sequestration into third space and it can cause shock. Patient is in distress and abdominal examination shows involuntary guarding and rebound tenderness in case of perforation. The diagnosis is simple. Chest X-ray shows free air in about 80% of patient. Treatment: nasogastric aspiration, analgesia, antibiotic and resuscitation. And here surgery is a must. Few rare cases, if the perforation has sealed spontaneously, non-operative management can be considered in ICU. And there should be no clinical peritonitis. These are for the conservative management but not commonly done. So the treatment is surgery for a perforated peptic ulcer, either gastric or duodenal, with a Graham patch technique. So last is question is for us: discuss clinical features and management of malignant neoplasms of kidney. I think we have considered this in one of our lecture. Just go through that. So what are the tumors of kidney? We are at clinical features. First, tumors of kidney, mostly they are benign or less, adenoma, angioma, and angiomyolipoma. They are unusual. Commonest for us is a renal cell carcinoma, that is RCC, also called as hypernephroma, Graves' tumors, clear cell carcinoma, or intramus tumor. These are different names. Common name is hypernephroma, CCC, clear cell carcinoma, and Graves' tumor. It is an adenocarcinoma. Incidence 2% of all tumors, more common in males. Risk factors for RCC: age, that means older age, male sex, obese patient, hypertension, either a cause or associated, cigarette smoking. Okay, and other medical conditions with RCC: chronic kidney disease, patient undergoing repeated hemodialysis. And unfortunately, after kidney transplantation also, there are chances of a malignancy. What is it called as? ACDK, acquired cystic disease of kidney, can undergo malignant changes. And as usual, the genetic factor. These days, genetic factor is playing role everywhere. It is a familial renal cell carcinoma, have different mutations of at least 11 genes. Names are very complicated, even I don't remember. Clinical features, just remember this red pen. Classic triad of line pain, line mass, and hematuria. This is a triad of a RCC. Hematuria 30%, pain is clot colic. Severe pain stops after some time. Dragging discomfort in line. And for you, everybody must know, this mass moves with respiration because the kidney is attached to diaphragm. It is touching diaphragm. Mobile, nodular, hard with dull renal angle. So dullness in renal angle and resonant band in front. Dull posteriorly, resonant anteriorly. And the ballotability. Ballotability is a sign of a kidney mass or kidney. Left-sided varicocele is a very common presentation. It is seen in irreducible left-sided renal cell carcinoma. A typical presentation: pathological fractures, hemoptysis. And one important thing is PUO. Pyrexia of unknown origin occurring in old age. In 20% of cases, this can be RCC. Remember this. Associated constitutional symptoms like malaise, lethargy, and severe anemia. There can be polycythemia, hypercalcemia, and hypertension. Nephrotic syndrome is rare. There can be different types of. One condition is Stafford syndrome. It is a non-metastatic reversible liver dysfunction which gets corrected after nephrectomy. That means liver function due to malignancy will be corrected after nephrectomy. Investigations: routine, urine microscopy, intravenous urography, USG, CT scan, CT chest, renal angiogram, bone scan, inferior vena cavagram, and MRI. These are all investigations which will be leading to the diagnosis. Okay. Now this figure is self-explanatory. It stages. This is the staging. This staging is now latest classification. Stage 1. Tumor more than 7 cm in largest dimension and limited to kidney. Stage 2. Tumor more than 7 cm in largest diameter but limited to kidney. So this 7 cm is mainstay. Less than 7 cm in kidney, stage 1. More than 7 cm in kidney, stage 2. What is stage 3? Tumor in major veins, because these malignancies grow along the renal vein. That is why in surgery, renal vein and artery must be ligated first. Vein has to be ligated first so that clot does not go above the renal vein. And it is not extending into Gerata's fascia. Gerata's fascia is very important as a layer. If invasion of that will go to stage 4. So Gerata's fascia covers all the kidney. So stage 4, whenever the tumor goes beyond Gerata's fascia. Simple classification. 7 cm, 7 cm, Gerata's fascia involved, Gerata's fascia not involved. Okay. So what is the treatment? We'll go for in short. because ultimate treatment or treatment of choice, that is TOC, is open radical nephrectomy. It is a treatment. Why open? Because you have to ligate the renal vein first. Chemotherapy and radio, not very effective. What we are at these days, if the tumor is less than 4 centimeter, it is called as a nephron sparing surgery, where involvement of a solitary functioning kidney. Remember, unfortunate patient having a single kidney who has developed malignancy. So here maximum nephrons have to be spared. Unilateral carcinoma with functioning opposite kidney affected by a condition that might threaten future function. This is a RAS mutation. Low stage or less than 4 centimeter. Anywhere located. Nowadays, new targeted drug, very costly, it is sunitinib. Is the first line treatment for metastatic renal cell carcinoma. If you remember, very good. Chemotherapy sometimes given with vein blasting. And you can remove a thrombus or intravena cava extension by doing an embolectomy. And radiotherapy only is reserved for symptomatic bone metastasis. So I think we are coming to the end of what is called as all the revision classes we have covered. And now what, if possible, we start taking our clinics, online clinical examination methods and how it should be done. That is probably will start next week. If you are interested, you can write on your this telegram. So how many students are interested in the revision through the clinics? If I get more response, we will definitely go for clinical management. How to take clinic, how to take history, how to take each and every pathology. That means discussion about long cases, discussion about short cases. Everything we will cover in 3 to 5, 7 to 8 lectures. That means the month of December itself, if you students are interested to that. So anyway, thank you. Good day.